Good afternoon, everyone. First of all, at this outset, I would like to thank the organizers of IntPCON for giving me this opportunity to speak on this particular conference. I'm especially thankful to Dr. Acharya Chetan Kumar and Dr. Nancy Loipalati for giving me this opportunity. And even I would like to, at this moment, I would even like to thank them for giving me the opportunity as a joint organizing secretary for this particular conference. So I'll be starting with the topic of molecules in pipeline for shock. Now, when we talk about these molecules, shock as such, not much has changed in the treatment of shock over the past 5 decades. And we would be talking about shock or my but lecture would be on these particular titles that we are starting with introduction, types of shock, treatment of shock, with what is the role of endogenous catecholamines, exogenous catecholamines, other drugs for shock, the newer drugs for shock, conclusion followed by bibliography. And I hope that I'm able to give an insight of few of the compounds which I found when I was going through the literature search regarding the treatment options that are shock that are there for shock. And also I've included a few animal models which I found quite interesting to be as a part of this particular talk. So, as such, when we talk about shock, the shock is defined as an inadequate organ and peripheral tissue perfusion, and it could be categorized on the basis of etiology as being either it could be hypovolemic, cardiogenic, or restrictive. Restrictive shock is further categorized as vasodilatory or distributive. Now, the other particular classification that is given to them is cold shock and warm shock. Hypovolemic shock and cardiogenic shock are labeled as cold shock, whereas septic shock is labeled as a warm shock. Now, what exactly is this cold shock? What happens is when we talk about this shock, there is a change in blood pressure, which leads to a change in the resistance of blood vessels as well as a decrease in cardiac output. This particular decrease in cardiac output results in decrease in stroke volume, which further causes a increase in heart rate, and there is vasoconstriction because of the release of catecholamines, thereby causing the vasoconstriction of blood vessels of the peripheries, leading to cold and clammy skin. Now, this is what exactly they say about the cold shock. And for the warm shock, they say that there is a rise in systemic vascular resistance, which is due to vasodilatory phenomena. It is due to basically arterial vasodilatation that is there. And this particular vasodilatation leads to a rise in blood flow, leading to an increase in heat production, and then this is labeled as warm shock. And there are some particular compounds such as nitric oxide that has been implicated as one of the causative agents for vasodilatation. Apart from this, there is also endothelial damage, which could be as a result of release of leukotrienes, proteases, prostaglandins, and thromboxane A2, causing vasodilator phenomena, thereby leading to warm shock. Now, when we talk about the treatment of shock, as I started in the beginning, uh, not much has changed. And my focus would not be on the etiology. My focus would not be on any other aspect. I will not be talking about the IV fluids. What I would be talking about is I would be talking about the main drug therapy that is used to raise the blood pressure and to increase the organ perfusion inside the body. And for that, we tend to use endogenous catecholamines, which have been present, which are being used for the past 5 decades or more. And then we have other vasopressor agents that are used. So, when we talk about the endogenous catecholamines, we have epinephrine, norepinephrine, and dopamine. Obviously, each has its own advantages and disadvantages, and we'll be talking about these advantages and disadvantages in the coming slide. Then there are certain exogenous catecholamines that are used, such as dobutamine, isoproterenol, phenylephrine, milrinone. Apart from these, there are other vasoconstrictors that are used, such as vasopressin, celepressin, calcium sensitizing agents like levosimendan, cardiac specific myosin activators like omecamtiv mecarbil, istaroxymes, and natriuretic peptides like mesetride, which have been used for shock, maybe as an adjuvant or maybe as a mainstay of therapy. So we'll be talking about each of these particular compounds one by one as we come across them. Now, when we talk about these adrenergic agonists such as epinephrine, norepinephrine, and dopamine, we all know that these particular drugs, they bind to the alpha receptors that are present on the membrane. These alpha 1 receptors activated lead to activation of phospholipase C. This particular activation of phospholipase C phosphorylizes the various structures that are present. Plus, it also binds to the IP receptor present on the calcium, and it also binds to the sarcoplasmic endoreticulum calcium channels that are there. It is also presumed to be bound to ryanodine-like receptors that are present in the inside the cell, and thereby it causes a phenomena of vasoconstriction. Now, epinephrine, as such, when we talk about epinephrine, we have been studying right from our beginning that epinephrine has equal affinity for alpha 1 receptors, alpha 2 receptors, beta 1, beta 2 receptors. So, epinephrine has been found to be useful for the treatment of acute left ventricular failure, especially during cardiac surgery, and it is said to be a most useful inotrope in these patients who are hypotensive and no myocardial ischemia. And obviously, we know that because it tends to increase the heart rate, it tends to act on the beta 1 receptors because of this positive chronotropic effect. This particular drug has limited utility due to the development of atrial and ventricular arrhythmia. And there is also a possibility that this particular drug could cause an elevated lactate levels that are there, that are encountered. And especially if the patient is having myocardial ischemia, the chances of arrhythmia and sudden death increases, or the mortality in cardiogenic shock increases many folds whenever epinephrine is given. Norepinephrine, as compared to epinephrine, is more selective on the alpha 1 receptors, and thus it is a vasoconstrictor but has a less potent inotropic effect. And as per the septic shock guidelines, norepinephrine is said to be the first line vasopressors for all form of shock where patient comes with severe hypotension. Now, apart from these, we have other group of drugs that are given, such as dopamine. Now, dopamine binds to another sympathomimetic, which binds to the dopamine 1 receptor, dopamine receptors, the beta adrenergic receptors, as well as the alpha receptors. Now, when dopamine binds, what it does is it binds weakly to the beta 1 adrenergic receptors, dopamine receptors, and it's also said to enhance trace amine associated receptor, which are also known as TAR1 receptors. But when we go at a higher infusion rate, that is somewhere around 10 to 20 micrograms per kg per minute, the alpha, it tends to also bind to alpha 1 adrenergic receptor mediated vasoconstrictor, which tends to dominate the peripheral response, and no longer recommended for vasopressor support in shock, except in patients with bradycardia who have a low risk of developing cardiac tachyarrhythmia. And in a dosage somewhere around 2 to 5 micrograms per kg per minute, or maybe around less than 10 micrograms per kg per minute, dopamine has found to be increasing the perfusion of the kidneys, and has been found to be quite an effective drug uh, uh, for treatment of hypertension. However, another particular point is that whenever we are going for infusion of norepinephrine, this norepinephrine could have a direct toxic effect on cardiac myocytes, because it tends to induce apoptosis via protein kinases that it tends to activate. Now, there was a study done. This is somewhere the study was done or published in New England Journal of Medicine in the year 2010, where what they did is they tried to compare the conventional doses of norepinephrine versus dopamine in patients of shock. And what they found was that both these drugs were quite effective for the treatment of shock, to elevate the mean arterial pressure. And what they the cardinal findings that they gave were that there was no significant difference in the rate of death at 21 days, at 28 days, sorry, and there were more amount of arrhythmic events that were associated with patients who were treated with dopamine. And what they did, they further went for subgroup analysis where they tried to analyze patients of cardiogenic shock, hypotensive shock, as well as septic shock. And in one particular subgroup of patients, they found this subgroup of patients was the patients with cardiogenic shock, where they found that dopamine increased the rate of death at 28 days among patients who were admitted with cardiogenic shock. And overall, they also tend to emphasize that dopamine was associated with a greater number of adverse events as compared to norepinephrine. So these were about comparative analysis of dopamine and norepinephrine. So as far as suggests that norepinephrine stays as the first line drug for the treatment of for the increase in mean arterial pressure. Then there is also use of exogenous catecholamines, and to be more specific or more precise, there is an increase in use of dobutamine as well as isoproterenol for treatment of for rise in the in the mean arterial pressure. So these particular group, these two drugs, they act on the as a beta agonist binding to the beta receptors, activating the adenyl cyclase, causing a further a release of calcium, and this calcium then causes a release of increase in cyclic dependent cyclic AMP levels. It also tends to increase the cytoplasmic calcium levels, leading to relaxation of vascular smooth muscles, causing vasodilatation. Along with this, a drug acting on beta receptors would have a positive inotropic as well as a positive chronotropic effect. So, when we talk about dobutamine and dopamine, so dobutamine is as a dopamine congener, but it is more specific on beta 1 receptors and has a weak affinity for beta 2 receptors. So, what it does is it tends to substantially increase the stroke volume and cardiac output with a moderate increase in heart rate, and it has an inconsistent effect on the mean arterial pressure. So varying doses of this particular drug has been related reactions to dopamine by the peripheral vasculature. Whereas when we talk about isoproterenol, which is a non-selective beta adrenergic agonist, which has low affinity for alpha adrenergic receptors, it has a profound chronotropic effect. And when given in septic shock, it tends to improve both the mixed oxygen, venous oxygen saturation and cardiac index. Another drug that has been used as exogenous catecholamine is a phenylephrine, which is a powerful vasoconstrictor due to its potent alpha adrenergic activity. And as per the surviving sepsis guidelines that were issued, phenylephrine is contraindicated in patients with septic shock, except when the septic shock persists despite the use of 2 or more inotrope or vasopressor agents along with low dose vasopressin. Cardiac output is known to be high, and norepinephrine is considered to have already caused serious arrhythmia. So if there are these three situations, then only there is a consideration of giving phenylephrine in case of septic shock. Otherwise, phenylephrine is contraindicated in cases of shock. Another drug that is used is milrinone, which is a phosphodiesterase 3 inhibitor. And what has been suggested is that this particular drug, it tends to increase the heart contractility while it significantly decreases both the systemic vascular resistance and the pulmonary vascular resistance. Apart from this, it does not stimulate the beta 1 receptors, so its inotropic action persists in the presence of concurrent beta blocker. That gives it's a significant advantage to be used, or the use of this particular drug in cases of cardiogenic shock. Now, this particular drug, it acts on the degradation of cyclic AMP to A5 AMP, and that is where this particular drug tends to act. It increases the level of cyclic AMP, whereby it causes increase in heart contractility while significantly decreases both the systemic vascular resistance and pulmonary vascular resistance due to vasodilatation that is associated with it. So a meta-analysis was done on the use of milrinone versus other drugs in cardiogenic shock, and it was a meta-analysis that was published somewhere, I believe, in 2017, and it gave two inferences on the fatality and on the adverse effect profile of the drugs. And when we talk about the ability of the drug to reduce fatality, it was said that milrinone is the most effective drug as compared to conventional treatment. Milrinone was followed by levosimendan, then norepinephrine, then the nasalitide, dobutamine, and so on. Whereas when we talk about the side effect profile, it was found that milrinone had comparatively less side effects as compared to dopamine. Dopamine was associated with maximum side effects, and it, recombinant nasalitide or recombinant human brain natriuretic peptide were drugs that were found to have better safety profile as compared to other drugs such as norepinephrine, levosimendan, or conventional treatment. So it was found that milrinone could be a drug that could be safely used in cases of cardiogenic shock if the patient is not responding to the conventional treatment. Other drugs that have been used or currently being used are vasopressin. Vasopressin is antidiuretic hormone, or arginine vasopressin as it is called, and this particular drug acts on the V1A receptor, 1B receptor, and V2 receptor. The primary action for this particular drug is it causes vasoconstriction and it leads to maintenance of hemostasis. Apart from this particular drug, it tends to reduce the pulmonary vascular resistance and it increases the systemic vascular resistance that is encountered once vasopressin is started. It causes, apart from this, it causes an increase in vascular sensitivity to norepinephrine and also tends to restore relative vasopressin deficiency. But there has been some concerns that higher doses of vasopressin can cause mesenteric ischemia, thereby there is another particular probability that is associated with these vasopressin is because of fluid retention that could be there, that could possibly be there when vasopressin is given. So conventionally, vasopressin is combined in cases with norepinephrine if a patient is not responding to norepinephrine for a rise in mean arterial pressure. So sometimes vasopressin is also combined as one of the mainstays of therapy to increase the mean arterial pressure in these patients. We have another group of drug that is the calcium sensitizing agent levosimendan. Now, this particular drug is an inotropic agent which has vasodilator properties, and this is specifically used in cases of acutely decompensated heart failure. What it does is it sensitizes the myocardium to calcium, and this it does by binding to the cardiac troponin C and opening of ATP sensitive potassium channels in vascular smooth muscles. Now, this particular drug has been found to be cardioprotective because it tends to open the mitochondrial ATP sensitive potassium channels in the cardiac muscles. It has been shown to have anti-inflammatory, antioxidative, and anti-apoptotic properties. Apart from this, it also tends to decrease the ischemic reperfusion injury that is associated in cases of shock. The mechanism of action of levosimendan has been implicated, as we were talking about previously, that it tends to open the ATP sensitive potassium channels, and it also binds with the troponin by releasing the calcium, thereby increasing the relaxation. Then we have another group, some more few agents that have been used, which are cardiac specific myosin agents. Now, one of them is omecamtiv mecarbil. Now, this particular drug, omecamtiv mecarbil, is one drug that tends to enhance the myosin cross bridge formation and duration by specifically activating the myocardial ATPases and accelerating the transition rate. Leading to what it does is it leads to prolongation in the systolic ejection time. It increases the cardiac contractility and also tends to improve the energy utilization. it what it does is it causes an accumulation of cardiac myosin just prior to ventricular systole by binding to the actin filament at more sites and in greater affinity. So once it does this, there is more effective ventricular contraction. So there is an increase in the left ventricular systolic ejection time, and increased sarcomere shortening, and improved stroke volume, while leaving the systolic blood pressure unchanged. Omecamtiv mecarbil also tends to open the ryanodine receptors that are present, causing the release of calcium from the sarcoplasmic reticulum, and this could explain the elevated oxygen consumptions under baseline conditions. This is where its mechanism of action is depicted. This is where it is binding the actin myosin, and it tends to increase the binding of this particular actin myosin, so leading to more effective contraction of the ventricles. Another drug that is used or that can be used is istaroxime. Now, this is one drug that tends to inhibit the sodium potassium ATPase and also stimulates the calcium ATPase isoform 2A that is located in the sarcoplasmic and the sarcoplasmic reticulum. It leads to the sarcoplasmic reticulum to reuptake of calcium during the ventricular diastole, causing an increase in cardiac output without increasing the heart rate or causing cardiac arrhythmias. And what has been found out, studies have found that in acute heart failure, when isotoroxime is given, it tends to increase the systolic blood pressure, reduces the wedge pressure, heart rate, and the left ventricular and diastolic volume. Natriuretic peptides have been used, or these natriuretic peptides. This is a human recombinant brain natriuretic peptide is a vasodilator. It tends to enhance the sodium excretion, suppresses both the renin-angiotensin aldosterone system and the sympathetic nervous system, and it improves the dyspnea and reduces the wedge pressure. But has been found to have no mortality benefit. One of the studies that was done in decompensated heart failure, which was acute study of clinical effectiveness of nasiratide in decompensated heart failure, the Ascend HF trial, it showed that nasiratide had no effect on mortality or rehospitalization for heart failure within 30 days. So that means it had limited utility. Now, moving beyond what has been already been there, although we find this particular drug, celepressin, also being present in, or this particular drug is also given in few of the literature as one of the vasopressin analogs that could be given in patients, uh, with hypotensive shock who are not responding to uh, norepinephrine. This celepressin is a selective vasopressin 1A receptor antagonist. And what it does is, because it is specific to receptor 1A, it does not bind to 1B and 1,2. So it reduces the fluid requirement and limits edema formation, as has been shown in animal septic shock model. Celepressin has been shown to maintain adequate arterial pressure in the absence of norepinephrine, and it has also been shown to shorten the duration of organ dysfunction in patients with early septic shock. And in adult patients with early septic shock, it has also been confirmed that it lowers the net fluid gain among patients treated with celepressin. This is where this particular drug is different from vasopressin, because vasopressin also acts on V2 receptors. So there is a higher fluid gain, and this particular drug tends to cause a lower fluid gain. There are many studies, or there are many particular features that tend to support celepressin, and there are few particular literature that also refute the claims that have been laid by celepressin, and this is based upon a multi-centric trial that was conducted in 63 intensive care units across 5 countries, where it was found when celepressin was given with norepinephrine. So one group received norepinephrine with celepressin, the other group received norepinephrine with conventional norepinephrine of its placebo. So what they found out, that there was no significant difference between the two groups in the primary outcome of ventilator and vasopressor feed rates. They also found out that there was no significant difference between the two groups in the secondary endpoints that were 90-day mortality, kidney replacement therapy free days, or ICU free days. And the conclusion that they gave us, the conclusion that these particular group of scientists gave us is that celepressine offered no advantage over treatment with norepinephrine. And they had, when they looked into this particular trial, what they said was that this particular uh, celepressine group, what they were doing is, what they did was, what they tried to do is, they specifically they broadened the criteria of inclusion and exclusion, broadened the inclusion criteria, and it narrowed down the exclusion criteria so as to enroll more number of patients, leading to simplification bias. They also said that there was significant selection bias because the conventional, the celepressine, where this particular drug had been used, what they said was that there was so many ICU patients, and there were around 28 centers, and it's somewhere around 15 months period, and only for out of the 28 patients were enrolled, limited number of ICU patients were enrolled. And they also found out that the measurement of cardiac functions were missing. Plus, there was an increased risk of ischemic events that are associated with celepressine. Another vasopressin analog that is coming up, or that is being used, is terlipressin. Now, there's a physiological study that randomized around 20 patients with septic shock to terlipressin and norepinephrine. And what they showed was there was a significant drop in cardiac patient index among patients treated with terlipressin than among those treated with norepinephrine. Another drug that has been approved by FDA in December 2017 is Gayapreza, which is angiotensin 2. Angiotensin 2, I believe all of us are already familiar that angiotensinogen is converted into angiotensin 1. Angiotensin 1 is converted into angiotensin 2, which acts on angiotensin receptors and is a vasoconstrictor. And the approval of this particular angiotensin 2 was based on the Ethos 3 trial. Now, this Ethos 3 trial was an use of angiotensin 2 for the treatment of vasodilator shock. Now, what they hypothesized is that patients who received angiotensin 2 were significantly more likely to achieve a mean arterial pressure of 75 millimeter of mercury or greater after 3 hours of study drug infusion, and patients who received angiotensin 2 had lower mean dosing requirement for baseline vasopressors over the first 48 hours following study drug initiation. They also found out that there was a reduction in the SOFA score after 48 hours following study drug initiation, were significantly greater in patients who received angiotensin 2. Then there was a particular study that was presented as an abstract in 2018 in an annual congress of the Society of Critical Care Medicine. And what they found out that administration of angiotensin 2 was associated with a lower 28-day mortality. But on further studying this particular research article, it was found that this study was underpowered to detect this outcome, and it was more of a hypothesis generating study only. Another study that was done, more of a subgroup analysis, where patients were examined with acute kidney injury who were receiving renal replacement therapy. And what was found was that receipt of angiotensin 2 was associated with a lower 28-day mortality as compared to placebo. And there was a likely significant patient crossover when details were sought out. It was said that there was a significant patient crossover, and placebo group had a higher amount of norepinephrine dose. So again, this was the study was more of a hypothesis generating study only. But what Athos 3 indicate that angiotensin 2 could be effective in providing hemodynamic support, and specifically it was effective for providing hemodynamic support or hemodynamic stability in patients who had acute respiratory distress syndrome, as angiotensin being majorly synthesized in the lungs. Now, when further analysis of this particular Athos 3 study was done, it was found, although they said that the total SOFA score, there was a change, but the total SOFA score was similar in both the groups. And there was no difference in 7-day mortality or 28-day mortality in patients who were receiving angiotensin 2 versus the conventional treatment. Apart from this, what they found out was what was there was that there was a significant risk of thrombosis, and this has also been put up in the package insert of angiotensin 2. Though this study, ATHOS 3, did not find difference in the rate of symptomatic venous thromboembolism, but this could be due to antithrombotic medicine administered prior to or concomitantly with initiation of the study drug. And what it was found was that this antithrombotic medication that was administered before or with the study drug, it was significantly higher or greater in patients receiving angiotensin 2. The other adverse event that was related was there was a increased event of infection or infestation was significantly higher in patients of uh, receiving angiotensin 2. Now, there have been studies that have been conducted on the angiotensin knockout mice, which has shown that they are more susceptible to infections. And on the other hand, when we have mice who have angiotensin 2, they are more resistant to infections. It was also said that angiotensin 2 could promote tachycardia through the modulation of baroreceptor control of heart rate. The rate of deliriums were higher in the angiotensin 2 group, but as such, the hypothesis that was given was that delirium tends to be common in all the groups. And it also was in a particular subgroup, it was found that angiotensin 2 had a higher rate of hypertension. Apart from this, the other thing that was of an important consideration was the price of angiotensin 2 that was quite higher as compared to the conventional treatment that is there. So what has been now is said is that this particular drug is better as a reserve to patients with distributive shock refractory therapy to high dose vasopressor therapy and stress dose corticosteroids. And in these patients who are refractory to high dose vasopressor therapy and stress dose corticosteroids, they could be where you could add angiotensin 2 as an adjunct. It was also, and this particular drug has been particularly found to be particularly effective at improving blood pressure in patients with acute respiratory distress syndrome. So that could be one of the indications where this particular drug could be used. Now, this is another compound that I found out when I was searching, that is nangibotide. Now, this could be, this is said to be inoterm, as the Roche inoterm is investing quite heavily on this. And what they have found out is that this particular drug is one of the first mechanism-based treatment for life-threatening conditions. And this particular peptide was designed to inhibit TREM1. And it also the initial studies have shown that it tends to improve the patient's scores on an organ failure assessment scale. Inotram TREM1 inhibitor hit the trial's main goal, that was it improved the morbidity scale related to organ functions and patient's clinical evolution over 5 days of treatment. And compared to placebo, was clinical, there was significantly higher concentration of STRM serum TRM1 level in this in patients who were receiving placebo. Nangibotide also improved the respiratory, cardiovascular, and renal functions in patients of shock. Another drug that has been found to be quite interesting and has recently been approved by the DCGI is canthaquine. So canthaquine is 2243-methylphenyl 1-piperazine ethyl quinone citrate, and this particular drug was first synthesized in India in somewhere around 1970s, but it failed to live up its role as a potential hypotensive agent. In high doses, it was used as an antihypertensive, but it was found to have limited utility. And it is like a rebirth of this particular drug, and it was observed that low doses of this particular drug increased blood pressure in rats with blood loss. So in the hemorrhagic shock model of rats, it was found that this particular drug could increase the blood pressure. Now, uh, what is the exact mechanism of action is? Now, this particular drug, it tends to stimulate the alpha 2b adrenergic receptors, and it leads to constriction of veins, which tend to increase the return to heart, and this increase of blood in the heart causes more blood to be pumped out due to an increase in ventricular contraction. Apart from being acting on the alpha 2 adrenergic receptors, it also acts on the alpha 2a adrenergic receptor, thereby reducing the sympathetic drive and decreasing the heart rate, thereby allowing the heart to fill up with more blood. Now, various animal studies and human studies have been done, and what they have found out is in one of the studies that was done in a rabbit blood loss model, it was found that canthaquine significantly reduced the amount of fluid needed to maintain a mean arterial pressure. This was somewhere around, as compared to placebo, which required 213, and this was required from around 126. Another study on animals in pigs, it was found that canthaquine reduced the amount of fluid needed as well as reducing the time it took for mean arterial pressure to reach target levels. This was somewhere around, in the placebo group, it was somewhere around 40 minutes, and in this, it was somewhere around 10 minutes. Then in rats, this particular study found the amount of norepinephrine needed to maintain a target mean arterial pressure was reduced in the group given canthaquine. So phase 1 study was conducted, and this phase 1 trial of intravenous canthaquine found out that this particular drug was safe and effective. Phase 2 study found that when canthaquine was used as a resuscitive agent along with standard treatment, patient had improved blood pressure, blood lactate levels, required less vasopressor, and reduced mortality. Whereas in a phase 3 trial, after 28 days, the mortality in the group given canthaquine was lower than control group. The blood lactate levels after 3 was significantly higher in the control group, and patients given canthaquine also showed an increase in pulse pressure and systolic blood pressure. Scores for acute respiratory distress syndrome and multiple organ dysfunction were improved in patients. Then we have another particular trial that has been quite openly being is the Danish cardiogenic stroke trial, where they are trying to compare conventional treatment plus placebo with conventional treatment along with advanced mechanical circulatory support, and the result of this particular trial will be out somewhere around in June 2023. So the primary outcome of this particular measure is death. The secondary outcome are MACE, mortality associated with cardiovascular events, combined safety, renal function, systemic immune inflammatory response, health economics, and hemodynamics. And what they are trying to do is they are trying to group study in a particular subgroup of patients who have ST segment elevation myocardial infarction complicated by cardiogenic shock. And we hope that these results will be somewhere out in January 2023. Then there were certain compounds that have been found, which are found interesting in animal models. We had certain drugs that tend to reverse the endothelial glycocalyx damage. And these compounds like adenosine, lidocaine, magnesium, which is ALM, and beta hydroxybutyrate plus melatonin and polaxamor 188. So what they hypothesized was endothelial glycocalyx is an integral constituent of endothelial barrier, and recovery and stabilization of this microcirculation is a major element for successful resuscitation regime. All these adjuncts, it was found, they tend to improve oxygenation and oxidative stress. And in vivo data suggests that adenosine, lidocaine, magnesium improve mean arterial pressure, heart rate, and survival in rats subjected to hemorrhagic shock. Adjunct use of beta hydroxybutyrate and melatonin increase the survival to lethal hemorrhagic shock in rat and improve 24-hour survival in swines who were subjected to hemorrhagic shock. Polaxamor 188 also reduced ischemic deperfusion injury and improved survival in hemorrhagic shock model. Resuscitation using ALM was capable of restoring plasma signature in one level. It also showed full restoration of glycocalyx thickness and recovery of vascular hyperpermeability, whereas BHB is a physiological energy source and melatonin is an antioxidant, and both these drugs could provide a favorable effect. The P188 has multiple potential activities like rheological, antithrombotic, anti-inflammatory, and cytoprotection, leading to improved microvascular performance at various levels, such as higher perfusion and oxygenation due to rheological alteration. All compounds were able to improve systemic parameters, partially restore hemorrhagic shock-induced endothelial collects, degradation, and recover other local functions in skeletal microvessels also. There was another animal model that I found interesting was distribution of vasoreactivity. Now, what was proposed was that vascular hyporeactivity leads to persistent hypotension because, and this is due to membrane hyperpolarization of arterial smooth muscles, which is caused by activation of ATP-sensitive potassium channels, which could lead to a low vasoreactivity in shock. So membrane hyperpolarization could also result in inhibition of potential operated calcium channels and reduction of calcium influx, which in turn led to reduction of the increased calcium influx of arterial smooth muscle cells stimulated by norepinephrine and reduction of contractile response. So what was the particular new concept was that when we block this potassium ATPA channel and prohibit the membrane hyperpolarization, we could improve the improve the vasoreactivity. So glibenclamide is one particular drug that could decrease the level of arterial smooth muscle cell hyperpolarization with an increase in norepinephrine stimulated calcium influx in the late stage of severe shock. Similarly, tyrone, which is a oxygen free radical scavenger, might decrease the formation of peroxynitrate with recovery of arterial smooth muscle cell membrane potential. So what did when they conducted this particular, they found that the norepinephrine threshold concentration increased 15 times more than the pre-hemorrhage value in all the groups. But as this increased when this particular glibenclamide and tyrone was given, it soon fell down to 6.1 and 7.4 times in patients receiving both glibenclamide plus tyrone and those receiving only glibenclamide. The effect of dopamine on blood pressure in the patients in animals receiving glibenclamide and tyrone was 1.8 and 1.9 times more than the control, and there was a steadily increasing mean arterial pressure post-treatment. Volumetric flow in the arteriole and each time after treatment was significantly increased, and also an increased survival rate. So these are some of the drugs that are used to conclude shock is difficult to categorize accurately and treat correctly because of its various etiologies and multitude of treatment options available. Therapies that are optimal for one type of shock might be harmful in another type of, so recognition of the type of shock is critical to successful therapy. The Surviving Sepsis Campaign guideline recommend norepinephrine as the first agent to be initiated for vasopressor support in patients with septic shock following adequate fluid resuscitation. And this is my bibliography. Thank you so much for giving me this opportunity and uh, sharing my viewpoints with all of you. Thank you so much.